Yesterday, we talked about valve sounds, where to listen, and introduced the different murmurs. Today, we're going to dive a little bit further into it and look at the physiology surrounding those murmurs. We are going to discuss different pathologies and the physiology associated with the aortic valve first, and then more will be discussed in class. If the valve is stenotic and the ventricle cannot eject, then our heart is going to have to get stronger to handle all of that excess pressure. This stenotic valve is just like having a high afterload or contracting against a high blood pressure every day. The muscle is going to get stronger and bigger. We call this hypertrophy. This gives the chamber a bigger squeeze. We've introduced contractility and stroke volume and equating it to pulse pressure, and this is no different. However, if the aortic valve is leaky, then this puts excess fluid back into the chamber where it came from. This excess fluid stretches the ventricles out in an attempt to increase the preload and cardiac output for the next heartbeat. We call this ventricular dilation. If we looked at the pressure within the system, then we would see a drop. The lack of the valve's integrity is what drops the diastolic pressure. A drop in the diastolic pressure can lead to a widened pulse pressure on physical examination. So, how do we tell the difference between aortic regurgitation and aortic stenosis when they both involve drops in pressure beyond the valve? In aortic stenosis, the pressure buildup is proximal to the stenosis, meaning that the left ventricle pressure increases, but the arterial pressure shouldn't change. All of the pressure built by the left ventricle is lost in the stenosis. During aortic regurgitation, that valve's lack of integrity is what drops the diastolic pressure, and there should be a near normal number when looking at the systolic blood pressure. One of the things to keep in mind with all of these valvular pathologies is that the body needs to maintain an appropriate cardiac output despite the underlying problem. Usually this entails some sort of remodeling. If we think back to the early lectures, we talked about two ways to improve cardiac output: increased contractility or increased preload. Well, your body does that in response to valvular pathologies in a way too. Building a stronger myocardium sounds a whole lot like increased contractility. Putting excess fluid into a chamber sounds a whole lot like the stretch principle or increased preload that we saw in earlier lectures. The underlying theme to remember here is that the body hypertrophies in response to excess pressure. Chambers dilate in response to excess volume. These changes are to maintain a level of adequate cardiac output, but these changes can also have some deleterious effects on other parts of the body. What if I told you that we had a leaky or regurgitant mitral valve? So early on in the pathology, a regurgitant mitral valve is going to have excess volume within the left atrium. This can back up in the lungs and lead to pulmonary edema. But we remember that our body dilates in response to excess volume, so left atrial dilation can accommodate that extra volume, which decreases our risk of pulmonary edema over time. However, this dilation of the left atrium is not without risk. The associated cardiac remodeling puts us at risk for arrhythmias secondary to atrial fibrillation, which in itself can lead to a decrease in cardiac output. So when you think about valves, their hemodynamics, and pathologies that are associated with them, think about the acute changes that happen within the body and then the long-term consequences of the remodeling. Again, thank you for watching and good luck with class.